You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about INOCA, ischemia with non-obstructive coronary arteries. Very interesting topic. The two main types of INOCA to know about are MVA and VSA. Coronary microvascular dysfunction causes microvascular angina, or MVA. In contrast, vasomotor dynamic epicardial coronary obstruction causes vasospastic angina, or VSA, which includes what was historically called Prinzmetal's angina. Let's start with microvascular angina. According to the 2023 AHA-ACC Chronic Coronary Disease Guidelines, microvascular angina is diagnosed using the definition proposed by the Covadis study group, involving 4 criteria categories. The first category is symptoms of myocardial ischemia, meaning exertional angina, rest angina, or exertional dyspnea. Category 2 is absence of obstructive CAD on coronary CTA or invasive coronary angiography. And by obstructive, they're talking about less than 50% diameter reduction and FFR remaining above 0.80. Criteria category 3 is objective evidence of myocardial ischemia, such as ischemic changes on ECG during an episode of rest pain, or stress-induced chest pain and or ischemic changes on ECG in the presence or absence of transient or reversible abnormal myocardial perfusion and or wall motion abnormality. That one's a mouthful, but it basically just means any ischemic changes on ECG, nuclear, or echo. Criteria category 4 is evidence of impaired coronary microvascular function, such as impaired coronary flow reserve, coronary microvascular spasm, abnormal coronary microvascular resistance indices, such as an IMR more than 25, or coronary slow flow phenomenon defined as TIMI frame count as more than 25. In terms of the impaired coronary flow reserve, that's something that you can assess on a PET nuclear stress test. Coronary microvascular spasm that was defined as reproduction of symptoms, ischemic shifts on ECG, but no epicardial spasm during acetylcholine testing. If all 4 criteria categories are present, then definite microvascular angina is diagnosed. If criteria 1, 2, and 3 are present without 4, or criteria 1, 2, and 4 are present without 3, then suspected microvascular angina is diagnosed. What do we do about management of microvascular angina? Baseline therapy, consider aspirin, statin, and ACE inhibitor therapy in all patients unless there's some sort of contraindication. They can have sublingual nitroglycerin as needed. Definitely implement smoking cessation and lifestyle changes. The first-line anti-anginal therapy is a beta blocker, carvedilol 6.25 mg BID up-titrated. Remember that beta blockers can and should be used in microvascular angina, but cannot be used in vasospastic angina. Second-line anti-anginal therapy is calcium channel blocker, substituted where beta blockers are not tolerated or ineffective, and these should be non-dihydropyridine calcium channel blockers such as verapamil 40 mg BID titrated. Third-line anti-anginal therapy is one of the following. You can consider a dihydropyridine calcium channel blocker, such as amlodipine, which can only be done for those who are on beta blockers without existing calcium channel blocker, because you don't want to be on 2 calcium channel blockers simultaneously. Or nicarandil, that's 5 mg BID up-titrated, which is available in Europe and Asia, but not yet in the US. Ranolazine, 375 mg BID up-titrated. That's what you need to know about microvascular angina. How about vasospastic angina? Vasospastic angina, which includes what was historically known as Prinzmetal's angina, manifests at rest, often in the early morning hours, the overnight sleeping hours, and in the absence of high-grade atherosclerotic disease. Coronary angiogram will show diffuse severe narrowing whose flow is relieved with administration of intracoronary nitroglycerin. Provocative testing with ergonovine or acetylcholine intracoronarily may be considered in cases where coronary vasospasm is suspected but not seen on coronary angiogram. Although no significant plaque is seen on coronary angiography, use of IVUS will show that nearly all sites of vasospasm have some sort of underlying atherosclerosis. According to the 2023 Chronic Coronary Disease Guidelines, vasospastic angina is diagnosed using one of the following definitions using three criteria categories. Criteria category 1 is nitrate responsive angina. Criteria category 2 is transient ischemic ECG changes. And criteria category 3 is coronary artery spasm. Let's see what they mean by criteria category 1, nitrate responsive angina. It refers to a spontaneous episode of angina that responds to nitrates with at least one of the following features: rest angina, especially between night and early morning, marked diurnal variation in exercise tolerance reduced in the morning, hyperventilation precipitating an episode, or calcium channel blockers, not beta blockers, suppressing episodes. What about criteria category 2, transient ischemic ECG changes? During a spontaneous episode of angina, there are the following temporary ECG changes in at least two contiguous leads: ST segment elevation of at least 0.1 millivolts, ST segment depression in at least 0.1 millivolts, and new negative U waves. Criteria category number 3 is coronary artery spasm. On angiography, this refers to transient or subtotal coronary artery occlusion, more than 90% constriction, with angina and ischemic ECG changes, either spontaneously or in response to a provocative stimulus, such as acetylcholine, ergot, or hyperventilation. Definitive vasospastic angina is diagnosed if nitrate responsive angina is evident during spontaneous episodes and either the transient ischemic ECG changes during the spontaneous episodes or coronary artery spasm criteria are fulfilled. Suspected vasospastic angina is diagnosed if nitrate responsive angina is evident during the spontaneous episodes, but transient ischemic ECG changes are equivocal or unavailable, and coronary artery spasm criteria are equivocal. Now that we've talked about the diagnosis, what should we do about management for vasospastic angina? If atherosclerosis is endothelial, if atherosclerosis or endothelial impairment are present, then aspirin and statin should be started. Sublingual nitroglycerin can be taken as needed. First-line anti-anginal therapy is a calcium channel blocker, just like for microvascular angina, verapamil 40 milligrams BID uptitrated. Second-line anti-anginal therapy is adding a long-acting nitrate, such as isosorbide mononitrate 10 milligrams BID. The third-line anti-anginal therapy is to change the nitrate to nicorandil, 5 milligrams BID, for example, which is available in Europe and Asia but not yet in the US. Even more important than anti-anginal therapy is addressing vasoconstricting stimuli. The main risk factor is cigarette smoking. Other than smoking, vasoconstricting stimuli include drugs, peaks in blood pressure, coal exposure, emotional stress, hyperventilation, and allergic reactions. Drugs that can precipitate vasoconstriction include SSRIs, ergot derivatives, 5-fluorouracil, and cyclophosphamide. Notably, vasospastic angina should not be aggravated by exertion. Other than microvascular angina, coronary microvascular dysfunction can also be seen in cardiac allograft vasculopathy, autoimmune associated CMVD, and CMVD of doxorubicin cardiotoxicity. One thing to remember is that the treatment of microvascular angina can be calcium channel blocker plus or minus beta blocker. But for treating vasospastic angina is calcium channel blocker plus or minus nitrate. You have to avoid beta blocker in vasospasm because giving vasospasm beta blockers can worsen the vasospasm. That's an important thing to know. Now that we have a basic understanding of the diagnosis of microvascular angina and vasospastic angina, we can go over a systematic method for diagnosing it in the cath lab. Nitric oxide is formed in endothelial cells by the action of nitric oxide synthase on L-arginine. And why do we care about this? Because in order to understand what you're doing in the cath lab for this diagnosis, you need to understand what you're giving molecularly. So I'm going to proceed, okay? Nitric oxide diffuses to neighboring smooth muscle cells where it activates guanylate cyclase, causing a rise in the cyclic guanosine monophosphate, CGMP, not CMP. Do not get that confused. That can be testable. And smooth muscle relaxation. Hypoxia, thrombin, and adenosine diphosphate are all stimulators of endothelial nitric oxide production. On the other hand, acetylcholine induces both endothelium dependent, which is nitric oxide mediated vasodilation, and direct smooth muscle constriction. As a result, acetylcholine induces vasodilation in healthy vessels, but vasoconstriction predominates in atherosclerotic vessels in which there is dysfunctional endothelium. In contrast, nitroglycerin and nitroprusside act directly on smooth muscle cells and do not require an intact endothelium to secrete nitric oxide. Nitroglycerin and nitroprusside will induce relaxation of vascular smooth muscle even in areas of dysfunctional endothelium. That's why this combination of medications works for testing. If you get CFR, coronary flow reserve, and IMR, um, the index of microvascular resistance, less than 2.0 and more than or equal 20 to 25 respectively in response to adenosine, that suggests coronary microvascular dysfunction is present. Again, if CFR is less than 2.0 or IMR is 25 or higher in response to adenosine, that suggests coronary microvascular dysfunction is present. You then follow that up with acetylcholine testing to see if epicardial vasospastic angina is present. If the acetylcholine induces at least 90% reduction in luminal diameter, development of angina or ischemic ECG changes, that suggests the presence of epicardial vasospastic angina as well. If CFR was at least 2.0 and IMR is less than 25 after adenosine, and there were no reductions in luminal diameter, no angina, no ischemic ECG changes in response to acetylcholine, then there is no microvascular angina and there is no epicardial vasospastic angina either. In patients resuscitated from sudden cardiac arrest, SCA, due to coronary artery spasm in whom medical therapy is ineffective or not tolerated, an implantable cardioverter defibrillator is reasonable if a meaningful survival of at least 1 year is expected. Class 2A. In patients resuscitated from sudden cardiac arrest due to coronary artery spasm in whom medical therapy is tolerated, an ICD in addition to medical therapy may be reasonable if a meaningful survival of at least 1 year is expected. Class 2B. So that goes to say that according to guidelines, just because somebody's sudden cardiac arrest is due to vasospasm doesn't mean that you shouldn't give them an ICD. So it depends on a few other factors. So that's what I wanted to go over for INOCA. We'll now briefly touch upon a couple related conditions, SCAD and cocaine-related cardiotoxicity. In SCAD, which is spontaneous coronary artery dissection, dissection of the medial layer of the coronary artery gives rise to an intramural hematoma that functions as a false lumen, which causes compression of the true lumen, resulting in ischemia and infarction. Another mechanism for SCAD is spontaneous hemorrhage of the vasovasorum, causing an intramural hematoma. SCAD accounts for nearly a quarter of cases of ACS in women less than 50 years old. In women who are pregnant or early postpartum, dissection may result from physiologic hemodynamic stresses or from hormone-mediated weakening of the coronary arterial wall. Multiparity increases the risk of SCAD due to repeated and chronic hormonal fluctuations. SCAD has to be managed conservatively. The 2021 ACC/AHA SKY guideline for coronary artery revascularization says routine revascularization for SCAD should not be performed. Class 3 harm. In patients with SCAD who have hemodynamic instability or ongoing ischemia despite conservative therapy, revascularization may be considered if feasible. Class 2B. Underlying causes of arterial fragility, such as fibromuscular dysplasia, should be investigated. That's SCAD. Now we'll briefly talk about cocaine-related cardiotoxicity. Intravenous and inhaled routes of cocaine have very rapid onset of action, on the order of seconds, compared to mucosally absorbed, meaning oral or nasal routes. The half-life of cocaine is 60 to 120 minutes. Cocaine causes systemic hypertension due to its inotropic and chronotropic effects, eventually leading to chronic hypertension. Cocaine causes the walls of the coronary arteries and aorta to become thin due to smooth muscle apoptosis and cystic medial necrosis, leading to coronary dissection or aortic dissection. Cocaine can also cause cardiomyopathy due to repeated sympathetic stimulation and altered myocardial and endothelial cytokine production. Cocaine causes platelet activation, which can cause vascular thrombosis. Myocardial ischemia results from the increased oxygen demand due to the inotropic and chronotropic effects of the drug in the face of coronary vasospasm and a prothrombotic state. Cocaine use actually confers a 24-fold increase in the risk of myocardial infarction in the first 60 minutes in individuals who are otherwise at low risk of MI, generally young individuals. Cocaine causes arrhythmias due to the increased sympathetic tone. Blockade of sodium channels can lead to bradycardia. Blockade of potassium channels can cause prolonged QTc and consequently torsade de pointes. If STEMI is due to cocaine-induced coronary vasospasm, administration of intracoronary nitroglycerin should cause the coronary arteries to become normal. The reason we withhold selective beta blockers such as metoprolol in cocaine users is due to the risk of unopposed alpha stimulation that could precipitate coronary vasospasm, although recent meta-analyses have called this line of thinking into question, so that whole statement is controversial. The acute hypertension of cocaine intoxication can be managed with benzodiazepines and nitroglycerin. With that, that's a wrap on this episode on INOCA, SCAD, and cocaine cardiotoxicity.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.